My name is Siddiqui, and I'm the chair of the Department of Community Health Sciences at the Khan University. And we are absolutely delighted to be talking on COVID-19. So the title of this session, which is a guest lecture, is Responding to the Global COVID-19 Pandemic. And this session is being given in collaboration with the Institute for Health Metrics and Evaluation at the University of Washington, and Bill and Melinda Gates Foundation. And of course, we are absolutely honored and delighted to welcome our two distinguished speakers, Dr. Ali Mokdad. Dr. Ali Mokdad is the professor and is the strategy advisor at the Institute of Health Metrics and Evaluation at the University of Washington. Dr. Ali Mokdad is also from the region. He is, I have to say, my old colleague and friend and from Lebanon. And he will be talking to us about COVID projections with particular reference to Pakistan. We are equally pleased to have with us Professor Dr. Anita Zaidi, Director Vaccine Development, Bill and Melinda Gates Foundation, but Aga Khan's very own. And Anita, we are very, very pleased that you are here to join us. And we'll be very pleased when you can later on give some reflections on COVID-19 pandemic and its relevance to Pakistan. We also will have with us our Dean, Dr. Adil Haider, the Dean of Medical College at the Aga Khan University. He'll be with us right through the session, and I'll be very pleased that he will be closing this session with us. In addition, we have other colleagues from Bill and Melinda Gates Foundation. So with that brief introduction, and without further ado, I would immediately turn to Professor Ali Mokdad for his presentation on COVID-19 projections with special reference to Pakistan. Before I do that, let me also say that we'll have the two presentations together, and following that, we'll have ample time for you to send your comments, reflections, feedback, and we'll be happy to respond to the speakers. We'll be happy to respond to your comments. So over to you, Ali.
Thank you and good morning, everybody. Thank you, Dr. Siddiqui, for the introduction. I have a long presentation that I will make available for all of you, and some of you may have seen the presentation by Chris yesterday. So I will go fast over some of the slides, focus a little bit on the results in Pakistan and the implication. So I want to briefly introduce the model, say the limitations for the data in Pakistan's projections for Pakistan, and how can Pakistan use our numbers, and how we can look all of us ahead what to do next. I'm presenting on behalf of a larger group here, and Chris Murray, who is our institute director, is leading this effort. It's the Chris Murray model, and many of us are working on this project right now. And for many of you who know IHME, we focus on three major critical questions. What are the world's health problems? How is society addressing them? And how can we maximize our outputs given our input? And we have been doing projections for SDGs and from the global burden of disease before. So it's not the first time we do projections. COVID-19 is a special case, of course. And our model started at the request of the University Medical Center here at UW. They asked us help in order to prepare for the surge, what they need in terms of beds, ICUs, and ventilators. So our model is basically how many COVID-19 deaths are likely to occur, how much daily deaths we are expecting, how many ICUs we need, how many ventilators, and how much has mobility changed in the past in order to impact the spread of the virus, and how many cases are estimated in the population, which is very important because due to testing, countries are reporting cases on a daily basis, but we provide also an estimate of the real number of cases adjusted for testing and how many have been tested as well. And basically it's a model, there's three versions of the model, three iterations of the model. I'll briefly mention them, but we do age and sex specific patterns of mortality. We have a median time from admission to death into hospitals. We have hospital discharge alive based on ratio of admission per death, ICU admission based on percentage of admissions, invasive ventilation based on percentage of ICU, and we use the median of length of stay in hospital to determine the need for bed. And we have other parameters that go into that model. And basically, we are, unlike any other models that started doing COVID-19, we decided early on at IHME to project mortality because we didn't know how many people are infected, because all countries early on in the epidemic didn't know how many cases they have due to testing, shortage of testing. So we take mortality in the past 8 days and we project it to the next 8 days. That's basically how we started. And we use that ratio of a number of cases in the past day to deaths, and we use it to project in the future. And when we have hospitalization, which is very important, when we have how many hospitalization and admissions we have, we can do a better job by taking the ratio of hospitalization to deaths, and we could do a better job in projecting deaths to the future. Early on, our model that was different from other models, especially the imperial model that came early on, we decided early on that if the epidemic is spreading in a country, pandemics throughout the world, but within a country, there are social measures that will be put in place, and we took 6 of them: closing educational facilities, non-essential business closure, people being ordered to stay at home, severe travel restriction. We've seen that in Wuhan, in Lebanon, for example, and partial non-essential business order to close and restricted group gathering. So we have these 6 variables that early on we used in our modeling of mortality. We used the experience in Wuhan and in Italy and Spain to inform our models. Basically, we told our models, as mortality and the death rate is increasing, there are measures that are in place, and that will be the impact based on the data and how we have seen in other countries. Force it on that model as well to make sure it doesn't keep going exponentially. That was a big difference between us and other models early on. So we have infections, deaths, and we use right now antibodies prevalence from surveys that are available. We have more and more surveys of those. We have hospitalization, ICU admissions, and ventilators need from many states and many countries as well. And now on our testing, our forecasting, we're looking at testing per capita, we're projecting that, mobility per capita, and we're projecting that. And we have now data on social distancing mandates and mask use from surveys. Google is adding questions to ongoing surveys. It's about 1 million a day. And we have data from Pakistan and many countries in the world. And we have social contacts rate and seasonality, of course, pneumonia seasonality. And we use this to forecast all the way. We have 3 models briefly. We had the first model that performed very well. It was a curve fit model. It's a non-linear model that followed the mortality projections very well in the United States until peak. It didn't do very well as the peak was coming down. So we moved to a curve fit, susceptible, exposed, infected, and recovered hybrid model in May to June 10. And that model was a combination. Still, we're using the mortality data, and we are adjusting our SEIR model to mortality, basically, so we don't go exponentially like the others. And since June 11, what I've been showing you today, we have moved to a random knot model, an SEIR hybrid model, where we are using different covariates, mask use, human contact rates, pneumonia seasonality, and testing per capita, population density, particulate matter, smoking, and in order to predict these variables into the future. Very brief, we take all the data that we have on testing, hospitalization, and deaths. We draw a 1,000 drove of daily deaths from each location. We use this mortality to estimate infection fatality rate by age and the distribution of time from infection to death, again by location. We use the SEIR model, and we do 1,000 times. We generate 1,000 model in order to get a confidence interval. We estimate the statistical relationship between beta, which is the covariate that we are using in our model, and other covariate. We forecast all these covariates to the future. We predict beta from these projected covariate in the future. We use that predicted beta to estimate infection and death in the future. And we take the predicted infection and death and hospital use. We use a macro simulation to go back from death to how many beds you need, how many ventilators, because we have data in most locations per death, how many admissions we had. And very briefly, this very hard to see, but I want to tell. This is Alabama, and this is death rate in Alabama by time, cumulative death rate. You see it is going up. This is cumulative case rate on the axis, and that's cumulative death rate. So there is a relation between cases detection and mortality. We explore that relation. We find out the relation. This is cumulative hospitalization on the axis. On the Y is the cumulative deaths. And if you look at the bottom here, we have cumulative case rate. We have a cumulative hospitalization rate, and you see cases are going up in Alabama. You would expect the epidemic to go up. But when you put all these three together, our predicted model peaked, coming down, and now we see a little bit more of an increase. That relation between testing, admissions is very important in order to get the good picture as we move forward. Excess mortality is a big problem for us in many countries, including in Pakistan. This is in Spain, where we have data on a regular basis on bi-weekly. We could see here COVID reporting and excess mortality, whereas for a country like Ecuador, same for Peru, you could see there is a huge difference between excess mortality and reporting from COVID-19. And we believe some of these excess mortality is due to underreporting of COVID-19. The beauty of our model is we can fit, because of our computational power here, for what we do on GBD, we can put 250,000 of these models, allowing us to estimate the uncertainty by each variable that we predict: hospitalization, deaths, needs for ICU, and so on. We have tested wide range of variables to be included in our models, starting by population density, household size, public transport, slums. In India, we're looking at even migration internally. All these variables have been added. To date, what has stayed in our model, which are very important: pneumonia seasonality, mobility, how people are moving, mask use, testing per capita, population density, and self-reported contacts. We find out that's very important. Mask use, we're finding about 50% protection for masks when they are used in terms of the association with less declining the transmission. We're adding to our model particulate matter 2.5 and smoking as well. Recently, we've been asked from colleagues in Pakistan to add humidity, and we are trying to include humidity in our model. This is always wearing a mask, every country in the world. And you could see in South America, not surprisingly, because right now they're going up in their infection. There is more mask use than what we see in the United States. India is doing a little bit better than Pakistan. Pakistan is doing much better than Iran and Saudi Arabia and Oman. Seasonality for pneumonia, this is in the United States. And you could see in one slide is the weekly and one slide is averaging for the past 10 years. And there is a strong seasonality for pneumonia. And we're seeing in our models, when we added seasonality, temperature early on was a good predictor. With 1 Celsius increase was associated with 2% decline in transmission. When we added pneumonia seasonality, temperature is not anymore a predictor, and it dropped out from our model. So seasonality for pneumonia is a good predictor right now, and we're using it for every country. This is COVID testing. This is on June 2nd. And you could see in countries, even within the United States, there is variation by state. But in our part of the world, you see less testing. And we have a couple of errors here. For example, if you look at Yemen, I know this is an error in Yemen because we use data from Aden and we projected it as the truth for the whole country, and we know that's not true. So we have some errors here that we need to fix. But that's in general self-reported data that we have by location about testing in every country. And I'll show you more about the testing in Pakistan. One thing about the cell phone app, and I have to admit that the data we are using on mobility and in contact comes from smartphones. So we're underestimating true decline in mobility because poor people in many locations don't have a smartphone: Yemen, Pakistan, India. But there are very similar patterns all over the world from our data telling us there was a rapid decline in mobility until April and started picking up in almost every location, which holds true even in the United States. This is mobility decline from baseline before COVID-19, and this is a June 11 mobility. You could see a huge variation in decline of mobility even within the United States. There is about 30 to 40% decline of mobility in Pakistan, which is very good. There is places in India that have more of a decline in mobility, but still Pakistan is doing better than Saudi Arabia, for example. example. All mandates in the world were put at the same time. So they came around a couple of weeks in every country in the world. And that's a very important thing to remember as we look at the data in Pakistan and the puzzle that we are seeing in Pakistan and India. If you look at every country in the world, and this is a regional, all of them were put about the same time. Within 2 weeks, they came into play. Pakistan, we have a lot of data sources. We have collaborators in Pakistan. We've been working with a lot of you in Pakistan. We're doing a subnational burden of disease in Pakistan, so I have a lot of collaborators, AKU. Dr. Zulfi is on our advisory for the GBD as well, and we work a lot with Anita and her team here at the Gates Foundation. But Pakistan government has a good resource available with some limitations, of course, due to under-testing and under-reporting of mortality, but we have data that are available to us on a daily basis that we could plug in. This is the probability of effective R, which is transmission from one person to another by provinces in Pakistan. And you could see here that in Punjab, Sindh, Khyber, and Islamabad capital, it's almost 1. So we are almost 100% sure that effective R is over 1 in these locations. And that's very important because we model effective R to get the transmission. To give you a picture of what's happening in the region, Kuwait is the circle where I have red, but that's similar to what we see in terms of effective R in Saudi Arabia, Qatar, and Iraq, where the epidemic is also going at a higher rate. COVID testing in Pakistan, from our data that we have, that we pulled out from the web and the government, you see there is a huge variation. But there is less than 4 per 100,000 and less than 34 in Islamabad in the city itself. So the huge variation in capacity of testing in the country, no surprise. Now I want to show you the data briefly of Pakistan and move into a discussion because I want to leave more time for all of us. We presented this to His Excellency, the Minister, and Dr. Siddiqui was in it, using our old models as of run towards the end of May. And then we told the Minister at that time, there are 13,000 projected deaths all the way to August 1st. So I want you to keep that in mind. But yesterday, Chris Murray made a presentation at the American University of Beirut and showed these numbers and showed numbers for the Arab world, excluding Pakistan, knowing that I will be presenting for Pakistan today to all of you. So he threw numbers out there for Sudan, Saudi Arabia, about 70,000, and Saudi Arabia, about 60,000. He even threw numbers on, and I'll make these slides available for everybody, and I sent them to Dr. Siddiqui, he'll share with all of you. And he threw number for Latin America and South Asia, and you could see South Asia, the projection here is a little bit over 500,000 deaths. So I felt very compelled to show you the data that we have right now for Pakistan, although we haven't finished our quality check on it. So please do not tweet it. On Tuesday, we will release the numbers. I couldn't run these numbers because many of you know we have a lot of issues here right now in Seattle and in the United States, and our staff have been told they can skip work if they need to because of the riots. And yesterday, Wednesday, and Friday, the university is off. We don't have, it's a day off, and people are spending their time to reflect and do whatever they want. So please don't tweet these numbers. We will have new numbers that we are updating on Tuesday, but I felt to show you these numbers so we could have a discussion about the situation in Pakistan. So please keep that in mind. 145,000 expected until end of September, with a peak in August 6th on mortality. So, and daily deaths in Pakistan. And social distancing in Pakistan, it came down to about 70% in our data. Remember, these coming from smartphones. Now it's going up. There is an increase about 30% of mobility in Pakistan, and daily infection and testing. We're expecting that we will have a lot of infections, about 400,000 projected by August 14. So really not a good picture for Pakistan. Most of the deaths, as you would expect, are from Punjab, 100,008. Same peak around the first week of August. Still mobility in Punjab went to 70%. We see the same pattern. Mobility is going up. Sindh is the 24,000, and then again, same pattern. Slides will be available. I have it Islamabad capital 3,000. I will throw this number. Azad, Jammu and Kashmir 3,264. And Balochistan 1,469. Balochistan is 1,135. So Khyber is 4,463. I really wanted to show these numbers, and please use the numbers on Tuesday to update these slides and use whatever you want. What are the limitations for us briefly? Under testing and under reporting in many countries, including Pakistan, we're not able to capture the expanded bed capacity. You know, I know at AKU, for example, canceling the elective surgeries, they're adding beds and increasing their capacity. We don't have that updated data. We get it on a regular basis. In Pakistan, we don't understand the testing that has been done, the 6,000 tests that have been done on a daily basis. What is the sample? How it's been selected? Who has been tested? Are these people who come to a hospital, or do we have a random test from people who are asymptomatic? And the fact that the sample is not done exactly the same way, so it's very hard to compare infections from one sample to another. We don't have a good hospitalization data. And we know from many countries in the region, I know in Yemen, for example, that many people don't go to the hospitals even if they have COVID-19. So main challenges as we move forward is balancing the impact of economy and saving lives, especially in poor countries and our part of the world. And then the under testing and then the under reporting. And there is a big debate, does immunity play a bigger role in some countries? And we don't know if there is any effect to that. And it's very hard for us to say that. I'm not going to spend a lot of time in our viz. There will be beds, how many beds you need on the peak day and during every day, and how you could use this data to plan. And of course, unfortunately, for planning for peak days, you have to plan at the upper limit, not at the average, but at upper limit. In location where we see now, what if we lift social distancing measure? In location where there's positive cases, especially in Pakistan, community transmission will resume. And that's what you're seeing in our projection, 145,000. It doesn't mean it's going to happen if there are measures to hold the transmission and reduce it. So transmission will go back to exponential growth unless the government and public health practice does something in order to contain that exponential growth. And we have to have a containment strategy, which is testing, contact tracing, isolation. And isolation in Pakistan, similar in Yemen, is very difficult. You know, people in Yemen right now, I mean, I heard yesterday that a team from the public health in Sana'a went to a house to pick somebody who's been exposed to test them. And his mom said, Muhammad is out to pick bread. Please sit down and wait. He'll come back and you can take him. It's very unrealistic to do isolation for poor people in my country, in Yemen or in Lebanon, where they need to go and get their daily bread and daily food because they don't have the capacity to store food. Our deaths may increase depending on the location, depending on social distancing and the behavior of the people, of course. We're expecting a second wave in Pakistan. Now it's picking up. In the US, we'll see a second wave in the fall. All depends on what the governments do and what the people try to do in order to reduce the transmission. We're trying to model what will happen and what if scenarios will be put in place in order to contain the second wave and the increase in cases. We're seeing a larger impact of seasonality coming in the United States from pneumonia. So we're going down in the US, but we are expected to go up. On our web released yesterday in August and in September. And we don't know how people and the government will they shut down and what need to be done in order to preserve. COVID spread in Pakistan. Everybody early on, Dr. Zulfi was on several calls with us, and we have faculty from us in India. We didn't see the rise early on when everybody in the world, especially in the Western world, peaked in COVID-19, and everybody was wondering what's happening. We felt at IHME that the data is not as good, mortality. And we were assured from a lot of our colleagues, Dr. Zulfi gave us a lot of advice on that in many of the hospitals where he is working, that, you know, they have this, they can tell us exactly what's happening. So my guess that when Pakistan implemented the social distancing, there was less circulation of the virus, less seeding in epidemiology, we say seeding. So that gave us in Pakistan and India and many countries in Yemen a false sense of security that COVID-19 is not going to spread in our country as much as we have seen in Italy and New York. And that was a false sense of security. Unfortunately, now we're seeing that that was true. Once seeding was introduced, once we had more cases in Pakistan, we're seeing right now an exponential growth. We expect that because of the global mandate that were put in March, that's what has reduced a lot of transmission, especially in countries. But right now, as I showed you, we're expecting a lot of mortality, around 2 million deaths in our new runs at the global level once we release this on Tuesday. What we need in order to move first, we need to improve our data on mortality. We need to do a random sample for antibodies in Pakistan. And to reduce the number, these are expensive tests, we have to admit that. We need to maybe consider doing a panel sample. So basically, if you're doing a sample, let's say of 500, 250 will be repeated, the same people, you recruit 250 new one, and so on. So you know, you increase your power of detection if there is a change from antibodies. And we could monitor in Pakistan what is the spread of the virus, how many people have been infected. We need hospital admission for COVID. And then right now in Pakistan, it would be good to know what is the testing breakdown. Is it in health facility? Is it from exposed? Is it from tracing activities that the government is doing? And then we know it varies from one place to another. And then from the tracing, how many number of people you're tracing per case and how many of those are positive? These questions we need to have an answer to. Now, realistic in Pakistan, when we talk to the minister about that, it's very hard to do it for a country as big as Pakistan, knowing the limitation and the expenses. Should we then do it in 3 areas? Should we take 3 small areas in Pakistan, low, middle, and high infection rate, and do that by monitoring burial sites, doing an antibody survey, and doing the reporting from the hospital, and do the contact tracing? So we answer these questions. We can do a better data and projecting the future for COVID-19. Again, we need to understand the balance between economy and health, but the public health message from these data that I'm showing you, wearing masks, keeping safe distance, and hand washing as much as possible. Our culture, you know, that's what I've been talking in Yemen. Our culture, our women covered their faces and they covered their mouths. Our man put something on their head in Yemen. So can we do better job in wearing masks? Protocol for safe opening of business, we need to do that. The country in Pakistan may consider something called a pulse approach. We're talking about it in the US, where as the cases increase, shut down seriously for 2 weeks and open again, shut down and open, so you don't shut down for a longer time. I know in Pakistan that are talking about selective lockdowns in certain cities. We lock down these cities. You have to take the reality in Pakistan. This may not work. People will move around. In England, there was a debate early on about a shielding approach where the elder population stay at home. Those who are young and healthy could go out because they're less likely to die from the virus. That doesn't work in Pakistan. We live with our parents and our kids will go to their grandparents. So again, the solutions in Pakistan have to be Pakistani, take into account the Pakistan culture. Can we open in Pakistan, and what can we do in order to move forward? Early disease detection, testing, tracing, and isolation. But we need protocols for phases of relaxation of the social distancing. My priority would be for the medical system in order to build the trust, people to come to hospitals for routine screening, prenatal care, immunization. This is a big concern in Pakistan. We need to maintain vigilance about immunization and other things. Then the second priority should be food security in Pakistan and transportation. And when you look at opening businesses, my advice to Pakistan, and I've been doing the same in the US, Chris as well, let's do what we call a prerequisite approach as we move forward. It's like we did in our college university. You have to take 101 to take 201. So can we decide as a country what businesses we need to open first in order to open the second level of businesses? And that way we have less people going out and about, and we give more chance to our public health system to do early detection and testing and tracing. Forthcoming, we were gonna expand for 4 months from now on. We will add the humidity, of course, as a variable at the request of the Minister of Health. I'm gonna stop here. We're monitoring how we do very well compared to other testing. I'm not gonna do this. I will stop and we'll open it for discussion, and I would look forward right now to hear from Anita. I will stop sharing. Thank you, everybody.
So, thank you very much, Ali. This was a very great, but a very thought-provoking presentation for all of us in Pakistan. And I think it's something that we need to reflect on. So, and I'm sure there are going to be a lot of questions and discussion on that. So since I talk about reflections, I would very much now turn to Dr. Anita Zaidi to give her reflections on what we have just heard on the COVID pandemic and its implications for Pakistan. And I think if she has the time, and if she could also touch very briefly on what is the current situation of vaccine development, because she deals and she's a director working in BMGF, we'll very much appreciate that as well. So with that said, over to you, Anita, and following that, then we will have questions and answers. And I've already received quite a few comments from colleagues. Anita, over to you.
Thank you, Samin, and thank you, Ali. So the situation is rather grim, and what we've managed to accomplish, and Ali went over this pretty quickly, but I saw the data last night. What we managed to accomplish is we delayed the epidemic in the hope that we prepared our health system. We probably saved many lives, and I think you have an estimate of how many lives were saved by that delaying of the epidemic. But now the crisis is upon us in a very big way, and the choices are not entirely clear. What's a no-brainer is wearing masks, public wearing of masks, and really a lot of social marketing on mask wearing is critical. And it's not there. Like I was out I was out wearing my mask today, and perhaps 10% of people on the street were wearing masks, which is way down from what it was a month ago when 30–40% of people were wearing masks. So I don't know why that has happened. Why has mask wearing gone down so much? Preparing our health system is the other thing that is possible, and here AKU is taking a very big role. And perhaps Adil, you will talk a little bit about what AKU is doing for preparing the health system at AKU, as well as helping other hospitals outside AKU. And vaccines, right? And so where are we on vaccines? I can spend 2 minutes talking about it. First of all, there isn't going to be a vaccine this year. That's the bad news. The good news is that it does not look like it's going to be hard to make a vaccine. Right, the technical part of this vaccine, because this bug is actually the area which we are targeting, is very stable, and it's there are many approaches out there which are all looking promising, which have all gone. They have many of them have good data from non-human primates, and now even good data from phase 1 studies, and a couple even in phase 2. We will have by the end of June, many phase 2 study results back, including on the AstraZeneca Oxford vaccine, the Moderna vaccine. Many others are going into phase 1 in this month. So one very promising one is Novavax. And then there are many others, including the Chinese vaccines. There is a Chinese vaccine that's also going to be in phase 2, which will be trialed in Bangladesh. But the tricky part of the vaccine business is that we need billions of doses, and nobody's ever made billions of doses in a year before, ever, right? And so that manufacturing has to start at what we call at risk, which means before you know whether the vaccine works, you have to start making it. And that means that you have to have billions of dollars that could potentially go to waste, because that vaccine might not be safe, or it might not be effective, or may need a different dose, or whatever. And so the problem right now is how do we get enough doses made before we even know whether this vaccine is going to work, for enough candidates out there, enough vaccines out there, that some will be available, and that's occupying most of my time right now. The Europeans and the Americans are doing what's called push funding, which is so through BARDA in the US, and the EC, European Commission, are giving manufacturers, like, buying doses before they're made, kind of thing. So with the understanding that if it doesn't work, it's all right, right? They're willing to put the money in at risk. The developing countries don't have the money to do, right? Developing countries don't have money to pay the manufacturers and saying, hey, make us so many doses, and doesn't matter if the vaccine doesn't work. So those are the sort of intense discussions that are happening around this what's called ACT Accelerator, standing for Access to COVID Tools, where people are saying the usual way of how we get vaccines for developing countries, where you have what's called pull funding, where Gavi will say that, you know, if somebody makes a vaccine, we'll buy it. That will work, but it wouldn't give you vaccine next year, right? Because first you have to then wait for the vaccine to work. Then Gavi will say, okay, fine, we'll buy this vaccine because it's working. That already puts you out in 2023 timeframe, right, or beyond. So those are where we're having, I mean, we don't have solutions right now. We're just having very intense discussions. One thing I'm pretty sure about is that, inshallah, next year we will have vaccines for healthcare workers everywhere in the world, right? Because that is a number. We think that there are somewhere between 20 to 50 million health workers all over the world. And if it's a 2-dose vaccine, which is what it looks like, unfortunately, for all of the candidates out there, then you need something like 100 million doses for healthcare workers. So that's what the first focus is to make sure that whatever vaccine is made, even if the rich world has bought them up, that we preserve some doses and somebody ends up paying for it. Through CEPI is one mechanism, Coalition for Epidemic Preparedness Innovations, which is something that I've had the privilege to co-create in 2017. And so we're hoping that through that there will be enough doses purchased for healthcare workers in developing countries, so that at least we can get that done in 2021, early 2022. I will leave it at that right now. Thank you.
So Anita, thanks very much. Thank you for the update on the vaccines. I think it was important that you talked to me about that. We have some questions and queries, and I will encourage people to send them and send their comments in writing. So let me start with the first one, which is actually about vaccine itself. And I think the question that has come up is that the challenge with vaccines is, and I think you partially answered that, is it because the nature of the vaccine changes, of the virus changes, and there is a bit of a mutation around that? Or is it that, you know, its behavior is quite unpredictable? Is that the main reason? Or it will be the human trials that will take the longer time? So maybe you have an answer, but perhaps you can emphasize.
Yeah. So it's actually, it's interestingly, it's none of the above, right? So we can, like I said, it looks like this is a virus that will be easy to make vaccine for and get high levels of neutralizing antibody. The clinical trials are already happening. Now, phase 3 trials, people were concerned about, is there going to be enough disease in the US to actually get so many phase 3 trials done? It looks like from what IHME's analysis is, there's certainly going to be a second wave, huge bad second wave in the US. The seasonality is helping right now, but it'll follow the pneumonia seasonality. And so there should be enough cases in the US to get a phase 3 trial done. And the other places where there is a huge bad situation right now is in Latin America. So many of the trials, the AstraZeneca trial, for example, is happening in, will be also adding in Latin America. So the clinical trials are not a insolvable problem. They will be solved. The issue is what I highlighted. It's the manufacturing commercially. Like commercial manufacturing of billions of doses takes a lot of money. And since we don't know which of these vaccines will work, and you have like 10 candidates, and each one you have to give $2 billion, let's say, then that's $20 billion we need now, right? And nobody's coming up with that kind of money. That's our big problem.
Sure, thanks. We're very pleased that we also have with us Dr. Zulfikar Bhutta. So Zulfikar, you did send your comments in writing, but maybe in a minute, if you could quickly make your comments and maybe we can hear all of you. So if you could unmute yourself and we'll be very pleased to listen to you.
Well, delighted. Well, thank you, Ali and Anita, and a very thoughtful session. So I have a series of 4 brief questions. So Ali, one of the big unanswered questions for me is why the insistence on such large scale volume of antigen testing, PCR testing right now, when the costs of doing so are becoming easily unaffordable for many middle income countries, leave alone low income countries. I'll just give you a quick scenario. At the current costs, my colleagues in Islamabad tell me that at around 50,000 tests a day, which is what WHO is recommending, this will easily cost us $150 million over the next 4 to 5 months. And this is now a disease where a large proportion of cases are asymptomatic, some are very mild, but those that we really need to focus on, present to hospitals, are syndromically detectable. So the question for you is, in the projections that we need for public health policy, could we not do a combination of, for example, hospitalized cases, mortality, and do away with this unreliable level of existing expenditure in countries? So I don't know how much value IHME has got from the existing testing data from Pakistan, because it's neither got the right denominators or the level of scale that it can inform any model. So that's something that I'd like you to project. And secondly, my big question for you is, I'll only ask two right now, is could IHME not do, in parallel to the direct effects of COVID on deaths and hospitalizations, also an estimate of indirect effects that are in parallel related to some non-pharmacological interventions? For example, people who have not received care because of lockdown, or children who have not been immunized. So that sense we'll get a balanced answer as to how many deaths are we preventing from the very measures that are in turn maybe exacerbating short-term or medium-term mortality or morbidity related to lack of services that have been induced by things as severe as lockdown. Thank you.
Okay, thanks. Over to you, Ali. I think those are two very important points.
No, thanks, Zulfi. These are, as usual, very smart and very good questions. So the first one, why do we need antibodies? And they're very expensive. They're running here over $100 per test. So they're very expensive. We don't need them when you have an epidemic going up. So between hospitalization and deaths, you should be okay. When you need them is when you're coming down in your curve, because you need to estimate what is the percentage of exposed and infected. And since we don't do enough testing, the infected you only can get from seropositive testing. So the trick here is what I mentioned, is to do a small sample size with a rotating panel, so maybe on a weekly or bi-weekly, at least to know what's happening with the infection number in order to use this susceptible, exposed, infected, recovered model. That's what you need. As an epidemic is going up, you don't really need to do that. Mortality is telling you. When you're coming down and you're coming down, you need to be more secure. Is this a true coming down and where you are? So that's the first one. The second one, can IHME do a microsimulation and say what's the impact of the lockdown and of COVID-19 on other conditions? Yes. And we have been asked to do that. And it's something that we are considering. And we will be running this, we'll be running this after we release all the COVID-19 for the world. Very good questions. We've been asked even at the economic implication as well. Over.
Can I just take the first question as well? So Ali, thanks for that. I think what Dr. Bhutta was asking was about the PCR testing, and it's a good question. Actually, the answer is quite so. The point about why is WHO harping on this and all of that is that it would help you in the tracing case contacts and isolating them. Now that's not working in our country, and you're not even able to get to the level of testing that you need. So I think it should be abandoned. There's not much value, and we'll have to end up doing what the UK was doing and whatever, which is very limited testing on very seriously ill people when there's a diagnostic dilemma, right? So I don't think that there is, unless you are doing many more tests and you have a really serious TTQ strategy where you are going and isolating and early in the epidemic. Now it's too late to do this anymore.
Sorry, Zulfi. I assumed you're talking about seropositive. PCR is worthless. I wouldn't recommend doing a lot of testing in a country like Pakistan.
That was exactly my point. So
I'll have to interject. We have quite a few other colleagues, and I would first sort of turn to a colleague from Shifa College of Medicine, Islamabad, and he says, I want to request, Anita, that's for you, if you could touch on some immunological aspects of COVID-19 and passive immunity. Could you shed some light on, you know, this antibody testing, the serosurveillance, and so on and so forth, very quickly? So that's a quick one for you, Anita.
So is he asking about serological testing or therapeutics with the?
I think both. He's talking about passive immunity.
Okay, right.
I think
So
he's a
passive
clinician
immunity,
apparently,
yeah.
and he wants to see what is the role of this passive immunization kind of thing.
Right. So convalescent plasma is promising. The clinical trials are ongoing. You know, there haven't been any placebo-controlled trials that have reported out yet. But observational data shows that there is some improvement, and there are some placebo-controlled trials that are being done. Now there are two other strategies that are also close to getting into clinical trials. One is hyperimmune globulin, and the second is monoclonal antibodies. And so over there for monoclonal antibodies, it could be, again, as I said, this virus, you can really get it. There is very high quality potent antibodies that have been developed that are being now getting into clinical trials, and so those are all promising. They may come earlier than vaccines. The problem with both hyperimmune globulin and monoclonal antibodies is we have to know dose, which we don't know right now. So if a low dose works, you could make lots of doses and potentially immunize all of your healthcare workers, not immunize, but give them prophylaxis. But if it's a high dose, if it's like a gram that you need, then unfortunately the economics will not work out because the cost will be $100, $200 per dose. So we don't know the answers to those yet.
Thank you, thanks. And now this is this is a clinician who sees patients on a daily basis, and I think anybody can answer this, but I think it's an important one from our perspective. It says, I'm receiving many patients in my clinic with fever, headache, myalgias. They could be COVID positive, but they don't want to be tested, don't have the money for testing, and don't want to go to the hospital or are scared of ventilators. What should I do with these patients? Are there any guidelines for this, basically?
I will defer this to the AKU clinicians.
So maybe Adil, I'll put you, if you don't mind, to tell us how would you like to manage this or respond to this question. So now you're responding to a question as an expert.
Sure. Thank you. I can understand the inhibition many folks have in actually getting the testing. The PCR test is expensive, and in many instances, the test could be way more expensive than the treatment that they would seek in that kind of a circumstance. So I could see why people don't want to get it. Most folks, many folks are just doing treatment like you would for a mildly symptomatic case. But the key there is to ensure that we can pick up the patients who are at risk of getting sick. So any of the immunocompromised patients, any patients with significant medical problems, it's very important to keep a close watch on them. And many people have, pulse oximeters, for example, are become ubiquitous. Many people, there's these Chinese ones that came, which in thousands and thousands of them are available. They're not that expensive. They're between 2,000 and 3,000 rupees right now. And people are using them. The key is what to do when you get that data. And people are frequently coming to the hospital when they watch the SATs go down to 60, and then they can't get into a hospital. So our trial, so I can totally empathize with the colleague who's asking that question. And what I would do is that I think most important thing you must do is that you probably need to see all of your patients in full PPE. That's the first thing. Second thing is that you need to make sure that many of these patients who are coming in, just like Anita was talking about wearing masks and so on, we have to create situations where even when people come into the healthcare environment, we're able to provide them with masks, and we've begun to do that at AKU. And then we have to take it on a patient by patient basis. I mean, if the patient is getting sick, we need to figure out a way to get these patients to a hospital. There are places which are open, and I think there are more places in the public sector where people are able to get treatment. But many of the large private hospitals currently are completely full, which portends a pretty negative situation right now, at least in Karachi.
Thank you. Thanks, Adil, for that. I have another one, and I think I just summarized that, and I'll just ask part of the question, and perhaps Ali, you could answer that one. It says, what do we need to do, or what do countries to prevent a second wave of the pandemic of COVID-19 in countries like Pakistan?
It's a very difficult one. So what we have known so far, that lockdowns work and they save lives. And that's what Anita said in her talk. So that closure is very important. And for the second wave, what also will help is to control the circulation of the virus right now. So when the seasonality comes down for Pakistan, is to make sure that you have less seeding and less circulation when you start the second wave, and then you lock down as early as possible. More adherence to the lockdown so you can get out of it much faster.
Thank you. So we have also a comment responding to, or following what Dr. Bhutta said, from Dr. Nuzhat Farooqi from AKU, and she says, if we were to stop testing, then I believe we also have to stop isolation as well. And then she puts a question mark. And all those patients requiring elective surgery, do they need testing before anesthesia? So those are the couple of queries from her, and anybody can respond, Adil or Anita.
I can respond to that. So, you should, if somebody is symptomatic, it should be assumed as COVID, and people should isolate, right? So everybody should assume that whoever has any illness right now, because we're in such high force of transmission right now, it's COVID until proven otherwise. That's our situation. And so same thing. Kind of remember standard precautions. If you have to assume everybody has hepatitis B, everybody has hepatitis C, so that you have to have that kind of mindset.
Yep.
Okay, thank you. I'll just raise one or two more points before I turn to Dr. Adil for his closing remarks. And Zulfikar, you had a couple of more queries. Do you want to raise them now before I finally, could you do that now very quickly? You had something on death projections, which are much lower in Pakistan compared to US. Do you want to say something on that?
Very briefly. So Ali, still notwithstanding the rising trend in Pakistan, if you still do the analysis of numbers, and not only taking IHME projections, but several other projections, including a model that we ran, the figures still come out comparatively lower than the disaster that we've had in the US or a couple of other places in Europe. What are your thoughts as to why the mortality burden is lower in some countries? I mean, I was speaking this morning to a colleague in Uganda, and they've been looking at this for the last 2 months. They've only had 2 deaths. So any real thinking beyond what we had originally discussed a month ago as to why the epidemiology might be a bit different?
I'm sure Anita has something to say as well. She's smiling, but Zulfi, no, beside what we had, you and I and others, that we had the discussion a month ago, we really don't know. And it's really a big puzzle. For me, is it the fact that you locked down early in Pakistan, you saved a lot of more lives and you don't see it right now? That's one. And is it the question mark I put it, which is I'm very concerned to say it because it sent the wrong message. Do we have some immunity? I mean, the fact that people who live in poor conditions and have been exposed to a lot of diseases, the young age structure that we have, the fact that we protect our elderly much more than anybody else, how we hold them at a higher regard. I don't know, Zulfi. These are puzzling questions that we don't have any answer for. Anita may have something.
I would agree. So I mean, there are some. So all of the things that Ali is mentioning are good hypotheses. There's also this that it's only a matter of time, and you just have to get enough transmission, and you have to have some super spreader random events like a large gathering, a very highly infectious person, and those things hit randomly. And when they hit, then that's when you see. And so sooner or later, the whole world will get it. It's just that everybody. It's when it will happen. It's not if, it's when. That's also a hypothesis out there.
Thank you. So I would like to thank
both. Question from Ali, Sami.
Yeah.
Ali, many people many people have asked, you project the curve and it's going up, and then in August it hits a peak, but then it starts coming down. Why does it even come down? Why does it just keep going up, up, up?
No, that's the difference in our model. We add in our model priors that when it peaks and mortality increases and people start seeing it, like what happened in Italy and New York, people are going to stay at home and there'll be measures and then it will start coming down. It's a reaction. I mean, look at what happened in Italy and New York. People in New York are staying at home and keeping a safe distancing more than anybody else in the world because of what they have seen, unfortunately.
Yeah, so that's a really important point. It's not herd immunity, right? It's not herd immunity. It's that when you see that much death happening, like when 500 to 1,000 people are dying every day, it will result in behavior change. That's the assumption that's built into the model.
And that's the reverse, actually, because you say wearing mask that Anita mentioned, and we're seeing it in the US. When you start going out and about and taking precautions and you don't see COVID-19 for 2-3 weeks, then you start letting your guards down. And the reverse will work. When you start seeing deaths, then you put your guards up again and it protects.
So Adil, I think this is time for me to turn to you for the closing, but I also have a question for you, and I think it's a perfect question for a dean of a medical school. And it is coming from a medical student from Rawalpindi Medical College, I believe. He says, is anyone looking at the impact on medical schools at the moment? And I think it's a great question for all of us to think about and something that we grapple with every day. So with that question, I turn to you for the closing remarks as well. Over to you.
Well, in a word, it's completely stopped medical education in the sense that for medical students. Now, of course, our residents and trainees, our postgraduates are on the front line across the country taking care of patients in difficult circumstances. And we've all known residents who have even contracted the disease, so they remain at the first line. The medical students in most places have not been brought into the response. At AKU, we are doing online teaching for our first and second year students, and we think we're not going to lose much ground with them because we can make up. For our third, fourth, and fifth year medical students, we do know we are going to lose ground. Especially because we have this belief that we must make sure that our education that our students get is the same quality in 2020 now than it would have been in 2019 or 2018, or when Dr. Anita Zaidi graduated from at least our medical school as a first class. So to ensure that high quality, we will have to probably move things forward, and you'll see much of that come in the future. I will say one big thing we did today at AKU was to have our first online examination. So, some of us remember taking, filling in those bubble sheets and so on. Today we did it all online. And I think that there will be certainly, that's probably going to be a positive change that many of our medical students will see. So there's certainly going to be some positivity from this. So with that, answering that question, I'll make my closing remarks. And the first thing I want to do is to thank the Department of Community Health Sciences and their chair, Professor Samin Siddiqui, who is also advising the national response. The way Community Health Sciences has worked through this pandemic, Dr. Samin, harkens back to the early days of CHS when it was the biggest, largest department, and what you've done in the last couple of years to bring the department to where it is, and just putting together a forum like this where we can have an open discussion about what's actually happening is just so tremendous. And if I could give a big round of applause to you, I think people are, we need to give it to you and the rest of the department and the great faculty, all those people who are modeling with you, Bilal and everybody, we greatly appreciate it. I also want to, I know we've heard lots of things, but I do want to take a minute to acknowledge Professor Anita Zaidi. Anita today, or yesterday, I believe, was announced as the President for Gender Equality at the Bill and Melinda Gates Foundation, and she'll do that role along with her role as Director of Vaccine. This is a huge deal. She will be the first director, and I could go on and say how we have all been inspired by her, but I'll just say this. I know that the future of women and girls is better in the world because of this appointment. I know that for sure. I also want to thank Ali Mokdad. Ali, you have, of course, done an incredible job around the world. I mean, you're everywhere doing these kind of models, and you're doing it completely selflessly. And as we really appreciate what you've done at AKU, you were here recently, but I think what you're doing in his example is an example of how this terrible pandemic has actually brought the world together. Whereas we're all suffering, we are, I think, getting closer because of this pandemic in numerous ways. And we know that humans respond in the face of adversity. And I think there are about 400 plus people watching this. I know the data that you just saw is very, very grim. In the sense that for Pakistan, you said that there could be 150,000 plus deaths by October. I know you don't want to be held to that number, but if you just think about the severity of that number, that's about twice the size of our last major disaster, which was the Kashmir earthquake in 2005, where about 85,000 or so people perished. That's double the size. People still talk about that earthquake, right? In all of our trauma circles, we talk about it. It is double the size of that. So when you think about how big this is, it's just unimaginable. But what I know is that we can still make a difference. So for the 400 people or so watching, I encourage you to yourself, we have to decide how are we going to do something about it. I'll give you 3 quick points about what we have been doing at AKU in particular. The first thing is we've been using these kinds of projections. So Samin's group has been working with other colleagues to come up with projections, just like you were saying, Ali, that you can determine, ICU usage, this usage, that. And we know we're in a surge. And unfortunately, every time we project, we know we can't do enough. But it makes us, it gives enthusiasm to our faculty. It encourages us to do more. And we've done a lot. And we're going to continue to doing more. And whatever we've done, you've seen we've done it kind of in the state-of-the-art way, from using negative pressure rooms to creating a standalone screening and testing zone and so on. And you'll see our capacity continue to increase. And our people really are on the front lines doing this. And I got to tell you that they truly are heroes. The other thing that AKU has decided that it's going to focus a lot on is public health awareness and education. Many of our experts from the faculty are part of the National Advisory Councils, Samin and our now famous Corona Wala doctor, Dr. Faisal Mahmood. It's everywhere. I mean, we have Dr. Zahra Hassan, with the lab testing. We have experts and we are encouraging them. We're encouraging our faculty to write op-eds, to be out there, to be public spokespeople. And then we've done thousands upon thousands of trainings for people across different things. And some of this, much of this has been supported by the Bill and Melinda Gates Foundation through a recent grant that they gave to the university. And we're very grateful for BMGF's support in that. In fact, I'll end with that one of the projects that they're supporting is a Pakistan-wide tele-ICU project. And this is the kind of stuff we need to be doing. In this project, we have ICU consultants, sitting there at AKU, and some consultants who are conducting from overseas. And they're talking to doctors and nurses and paramedics who are on the front lines taking care of patients in a way, and these kind of patients that they haven't taken care of before. So sick, ill patients who are now coming to high dependency units, who are coming to ICUs, creating a mechanism so that they can then get consults and help with rounding on the patients, improving the quality of those ICUs and so on. So there are many things that are going to come out of this. And we have to harness the positivity. And I think that if we all decide that we're not going to just watch what's happening, we're going to get up and actually try to make a difference. Inshallah ta'ala, we will not get to that 150,000 death rate. In fact, we'll be far below it. So thank you again, Samin, for this. And it has been we so appreciate being here.
Thank you, Adil. I know I've received a lot more messages, and maybe I'll send those by email to colleagues for their response, but we can't take any more steps because I think we've run out of time now. Thank you to the 2 speakers, Ali and Anita. Actually, it's a triple A, Ali, Anita, and Adil, and I think you've done a wonderful job, all 3 of you. Thank you very much. And Zulfikar, you were there. Thanks for joining, all the colleagues. It's been a great session, and we'll continue to follow up with this. And hopefully we will be able to meet face-to-face and do these kinds of works in our countries as well. Thank you very much. Have a nice evening. Have a nice morning. Have a nice day. Bye-bye.
Thank you.